Good evening, everyone. Welcome all to the second talk of the Innovation and Precision Eye Health webinar series. It's now 6:30 and we shall be starting on time. And today I'm very pleased that we have with us Associate Professor Katrina Schmid from the School of Optometry and Vision Science of Queensland University of Technology, Australia. And of course, I would say most of you will be familiar with QUT, in the short form for Queensland University of Technology, because I see amongst the audience, there are some past alumni as well, who are now practicing in Singapore as well. And of course, online, I can see there are other ophthalmologist colleagues and also optometrist friends who have logged in both locally from Singapore and also elsewhere. So once again, welcome everyone. And to get started, I would like to first introduce our speaker for today, Associate Professor Katrina Schmid. Professor Schmid first graduated from QUT with her PhD thesis on visual and retina control of eye growth and refraction. Her main research interests include refractive error development, myopia, accommodation, binocular vision, ocular surface, meibomian gland dysfunction, etc. Notably, she has been awarded 2 prestigious awards for her research work. First, the Classic Paper Award, which is awarded by OPO in year 2014, and the prestigious Lloyd Hubert Award, awarded by CXO in the year of 2020. And based on the bibliometric analysis for experts in refractive error, she's ranked 25th worldwide. And based on the Global Optometry Research Power Ranking, she is ranked globally 115. So it is our great honor and privilege to have her with us today and to share with us the role of near work in common myopia. And Professor Schmid, I shall hand over to you. Thank you.
Thank you so much, Professor Chung. I'm really honoured to be presenting to you tonight, and I really thank you so much for that introduction and for the invitation to be here with you all and to really share one of my most passionate research areas, something that I've been working on for a long time and that I'm really excited about. And I've purposely called this talk The Role of Near Work in Common Myopia, and I'm highlighting the yellow common because my talk today is really about that kind of myopia that so many children suffer from, that you see in your practices every day, the kind that just gets worse and worse and you don't really know why and what's caused it, and it's not pathological and it's not from a syndrome and it's not from sort of systemic disease, right? And that's what I'm really interested in. And so at the end of this presentation, I really hope that you answer or have a little bit of a better idea about some of these questions that I've put on the slide. Is something about our system emmetropizing to a near distance, evidence that prolonged near work is actually related to myopia and increases myopia risk. What's the accommodation system got to do with all this, and particularly lags of accommodation? And when we look up close, what happens to our ocular parameters, our components, how do they actually change? And then lastly, just what's some advice that you're going to tell your patients and what you're going to do there? So to start with, Professor Chung's given you a very nice introduction to me already, but I just want to highlight that my PhD was in chick myopia using an animal model, and that's why I've got a couple of slides on that at the beginning. And also that I do research in other areas. If you Google my name, you'll see other papers come up on binocular vision and amblyopia and ocular surface, and also learning and teaching pedagogy. And maybe I can give you some presentations on those topics at another time. Also, in terms of my research, and this is really related to something I want to tell you about myopia. You mentioned, I do have quite a large profile in terms of refractive error. I'd like to increase my global influence more than 150 up the chain, and hopefully I have a chance to still. But you can see that I have about 30 papers actually now with more than 30 citations. And some of the papers have got hundreds of citations. But what I really want to highlight here is that 2018, the citation, my papers, my past myopia work just skyrocketed from about 100 public citations per year up to like 400 citations per year. And that's coincided with the taking off of research that's been conducted overseas, the new myopia control therapies that now exist and all the work before that phase and also after that phase in myopia research. Papers on the chick model and using spectacle lenses and contact lenses as treatment options, and how the peripheral eye shapes involved perhaps in terms of peripheral defocus in myopia. But today I'm really just going to focus on near work and accommodation responses and what happens there. And in this talk, because I do only have a short time, I'm really going to focus on my research and show you some of the data from my papers that I've been involved in, and not the whole, of course, expanse of the thousands and thousands of papers that have been published on this topic. I'd also like to, at this point, acknowledge that the work that you're seeing, of course, is a team effort, and to acknowledge all my collaborators and past students that have contributed to the work. And they're all co-authors on the papers. So if you get any of those papers up, you can see the list of people that have contributed to the work. So to give you another step back and go to the overview of my talk, I'm going to look at what is emmetropization, because I don't think we can understand myopia and what causes myopia if we don't understand about the emmetropization processes. And a little bit, as I said, yeah.
Professor, sorry to interrupt. It seems like the network is a little bit unstable. Perhaps we can pause a little bit for you to resecure your network if necessary.
Yeah.
It seems fine now. Okay, just now your video was.
Yeah, I saw that it did come up with the query. That's.
Yeah, it seems fine now. Why not you go ahead? Thank you.
Okay. I will send a message to make sure my children are not on the internet as well. But it's 8:30 at night in Brisbane here, and that's one of the key times when the internet's being used. So let me just go over the slide again. So I'm going to first talk about a little bit about emmetropization, because you can't understand why people become myopic if you don't understand what the emmetropization process is. Some evidence that near work is related to myopia, data that shows what happens when the ciliary muscle contracts up close, and that those parameters vary with refractive error, how accommodation alters the axial length and the choroid, and then just slightly consider the outdoor mechanisms, how outdoor is protective and what is the potential mechanisms for that. So that's how the talk's going to go. So to start with, in terms of emmetropization, this is one of the classic curves that I show my students, and you may have seen this already in your refractive error lectures that you had as an optometry student as well. And this is data from quite a long time ago, when there wasn't all the environmental stress and differences on the system that there is today. So this is how a normal system kind of works, right? So the blue curve is the refractive distribution of newborns, so really, really young babies, children, and then over 6 to 8 years, what happens to those refractions. And you can see that infants are born with this huge spread of refractions. It's nearly even a bit flatter than a normal distribution. It nearly could have just happened by chance, that spread. And then over 6 to 8 years, we see the red curve, which is a leptokurtotic distribution, one that is much steeper than by chance. And we can see that the refractions are all coming to a point that's actually about +1 diopter hyperopic, not 0. But this decrease in refractions towards a lesser value is called emmetropization. And that's what we expect to see. And then when they've looked at animal models, we also see this in a wide range of animals that have good acuity and good vision. So at the bottom here is the emmetropization response in the chick. That's the model that I use through my research. And you can see the same sort of thing where there's a big spread of refractions, and then they come towards, closer towards zero and all being very similar. Same for the mammal models, same for the small primate models, the marmoset, and even for monkeys as well. So the whole idea is that this response is guided by vision and can be altered by visual feedback, and that the eye can work out what, that it's not got the refraction right and that it needs to do something to sort that and to fix that. Then we go, well, why isn't everyone emmetropic? What happens and doesn't get it right? Or we do get it right to start with in young children, and then it's later on that the myopia starts to develop and occur. And what is the reason for this increase in myopia prevalence that we see? And it's something that's happening after a couple of years. It's not that all the children are born really short-sighted, or they do go through that emmetropization phase, and then they develop myopia later. So we see in Australia, we have a much higher prevalence of myopia in our 18 to 25 year age group that's very educated and goes to university. When I get my students to put up their hands, how many are short-sighted? Sometimes I'll get 50 to 60% of the 18, 90-year-olds at university are short-sighted, but our general population, it's down at 15, 20%. And of course, in Hong Kong, and countries like Singapore as well, you'll see that the prevalence of myopia is much, much higher, going to 80, 90%, and it's just a huge global problem. And there seems to be that genetic predisposition, maybe to close work, maybe to the environment, that varies across the world. So in terms of myopia in our animal models, we can actually induce myopia in a number of different ways. We can deprive the eye of high quality form vision by putting translucent occluders over the eye, and that open loops the eye growth system and high myopia occurs. We can use lenses, so we put negative lenses that shift the image plane behind the retina. The eye elongates and grows to compensate for that hyperopic defocus. And if we put plus lenses in front of the eye, that shifts the image plane in front of the retina. And in our chick and other models as well, the choroid swells to push the retina forward and the animals become hyperopic. So we know that plus lenses, so myopic defocus, can decrease the risk of myopia, even cause hyperopia in models, but that hyperopic defocus is not such a good thing. And our animal models showed us this many, many years ago. Also, our animal models show us that the environment and the distance that we're looking at is very, very important as well. So here we've got chickens that are reared with these little cones on, and at the end of the cone is a target, a high quality target of some kind. And that's all the animal can see, this near target at 3.3 centimeters. And without that, any lenses in the way, they'll become highly myopic. They'll emmetropize to that near distance. And if we just change slightly the degree of defocus with plus lenses, so there's no defocus, they'll stay emmetropic. If we just put 5 diopters of that hyperopic defocus, we'll get 5 diopters of myopia. So they emmetropize and grow to that new target distance. They can sense the divergence, the error, and they correct to what they see. And I think that's important in near work when I sort of pose, is it that the human system is emmetropizing to that near distance as well, at least as a starting point to get the myopia started off in terms of its development? So there's quite a lot of evidence that shows that our animal models do become myopic, and animals do become myopic if they're reared in a near close environment, so small cages, unfortunately, or like you put them into that situation where they only see up close. So do humans do the same kind of thing? Do eyes become myopic just as an emmetropization response to the near work that's prolonged in duration? So that's the predominant distance that you're looking at. And of course, the question is, the animal models that I show you, they emmetropize to that near distance and then they stop. But the human eye doesn't stop. They start getting myopic to maybe towards a near distance and near work, and then it just keeps getting worse and worse and worse and never actually peters out until, you know, the eye growth process is totally finished when you're out of that critical period. Some more evidence that that myopia is related to near work is the fact that when we think about risk factors and we create a list of risk factors, of course, family history and genetic predisposition is there, but all these other factors come up as well that are related to close work and education. So the data shows that the amount of close work that's done, the working distance of how you read and what distances you read at, the age that you started school, the education that you have and the education demands, and even if you're doing an occupation that has a really lot of near work demand as well, like a microscopist we've shown, they have much higher risk of developing myopia. And then there's these links with accommodation and the binocular vision system as well. So there's lots of work in terms of showing that there's risk factors. There's other ones as well, but they're on the list and very important on that list. So again, in terms of near work and myopia, we see that there's lots of cross-sectional studies that have been found that increase the near work odds ratio. And the more close work you do, the greater your odds of becoming myopic. And a lot of this has been reviewed in very good systematic reviews recently. There's also longitudinal studies that show that there's a relationship between myopia and near work, and that it's the absolute working distance and duration of those individual periods of continuous near viewing that's probably important, rather than the overall amount of close work that you do per day. And I'll come back to that again at the end in terms of our advice. Shorter distances and prolonged close work are clearly much worse than holding things further away and doing lots of breaks and going outside all the time. And we also see an association between the fact that people who look up close all the time and then look into the distance, we can measure what's called a near work induced transient myopia response that eventually over time becomes a persistent myopia. So near work induced transient myopia after close work is also related to myopia progression. I mentioned just very briefly at the beginning, there's that if you deprive animals of high quality form vision, that they become myopic. And I wanted to show you this data that we collected quite a number of years ago because it's the PhD work of Dr. Anna Yao, who's here today and who invited me to give this presentation. So I wanted to show you what she did as part of her PhD. So we had this hypothesis that one of the reasons why near work was associated with myopia is because when you're looking up close all the time, you're just looking at black and white lines of text or Chinese characters, which kind of mimics a horizontal grading. And that's not changing. It's not a very varied kind of target. And therefore, over time, that the retina may adapt to that and retinal activity reduce. And we know in deprivation myopia, when activity goes down, dopamine levels go down and myopia is created. And we did show here, and you can see some of this data and have a look at the papers, that if you look at Chinese text or English text or a grading over time and then measure your contrast sensitivity after that exposure, that you adapt to that target, to the text that you've seen, and it raises the contrast threshold for then subsequently presented sine wave gradings. So this is actually the data here is log contrast adaptation. It's the change. A positive value is showing that your thresholds increased, and they increased both to English text and gradings and to Chinese text. And they increased a little bit more on the myopes than the emmetropes did. So it is possible that near work can induce a deprivation effect. It's not many other papers that have looked at this, but it's a possibility. So I just wanted to mention it. Looking outside, lots of different things. That's what your retina likes. It adapts if things don't change. The other part of the work that I wanted to show you was looking at about accommodation lags. So an accommodation lag is where when you're looking up close, the system under focuses for the demand. So if I'm at 33 centimeters, a 3 diopter demand, I should accommodate 3 diopters. But actually the system doesn't do that. It under focuses, and we have a lag of accommodation. And that means there's a hyperopic defocus when you're looking up close, and that's a bad situation. So this is some data from that classic paper that you actually, that Associate Professor Chung actually mentioned. And here is the data that we collected in that OPO paper showing that our progressing myopes under-accommodated. So this is an accommodation stimulus response curve. This is the response on the y-axis, and on the x-axis is demand. The one-to-one line means it's perfect, and under-focusing is under the line. And you can see that our progressing myopes, only the ones who were getting worse, these were young adults, didn't accommodate accurately. And this is always, we compared to the data from Jane Guiazda's work, which showed that children were even worse at accommodating up close. So the myopic children didn't do a good job at all. And so there's lots of literature on lags of accommodation, and that a higher lag is worse, and that there's higher lags in myopia. And I'm going to show you some other data that doesn't cancel that out, but shows that what we measure with autorefractors and with retinoscopy is not quite all that you need to think about. So this is now some data from another group's work, looking at lags of accommodation, and some work that we've done as well. And there are many other groups that have also replicated this, that shows that here's the green autorefractor or retinoscopy data, might be similar as well, that shows large lags of accommodation at near. But then if instead you do aberrometry data, you look at aberrations and you account for those with the RMS defocus, or you actually also do a subjective blur detection task as well, you find that actually the lags do not decrease visual acuity and vision and retinal, clarity as much as you would predict. So you might have, a plus, 1 diopter lag, one under focusing diopter, but once you account for all these things, it could be the equivalent of 0.25 or 0.50. And we show that as well for all these different kinds of ways that you can calculate the actual accommodation lag on the retina using, aberrations and using the visual function of what's actually being seen by the retina. So we find that when we do all that, we probably overestimate the lag of accommodation by about plus 0.50, by about 0.5. But we still see the fact that the lags are greater in our myopes than our emmetropes. So there's just something to think about when you're reading the paper, that the lags are not as great, so that hyperopic blur is not as great as you think it is. I still think it's important to measure how people accommodate and what they're seeing up close, and what the lag is, but just realise that you probably need to take about 0.50 off those values. The other thing that's really interesting is when you're looking up close, of course, your ciliary muscle is activated and acting. And we wondered if there was perhaps a mechanical force that's generated from the ciliary muscle around the back of the eye to elongate the eye that maybe causes part of the effect. And we have shown through using anterior segment OCT, so you can measure the ciliary muscle dimensions. You actually measure through the sclera and can actually image the ciliary muscle. And we do all these calculations and measurements. And we find that when you do those, that to start with, the ciliary muscle length and thickness, particularly nasally, is greater in myopes than our emmetropes. And then during accommodation, the anterior part of the muscle thickens more and the nasal muscle length shortens more. So that the ciliary muscle changes must have to be, I guess, greater in a big myopic eye than in a shorter emmetropic eye. And we propose that maybe that creates more mechanical force on the eye that leads to greater axial elongation. And there's, of course, Leon Davies and a lot of other groups who've worked on this as well. So ciliary muscle anatomy and physiology changes happen in myopia, and they might be important as well. Related to those biometry changes that I've mentioned in terms of ciliary muscle, we also, and that transient near-work induced myopia that we've observed for a long time, that happens. So after you look up close and you look in the distance, you stay myopic for a while. We now know that there's also a transient axial length increase. So when kids, even young adults as well, look up close for a period of time and we measure again the axial length with the lens star or the OCT or different devices, we find that there's this very small, in the order of, 10 to 20 microns, maybe 30 micron increases in axial length. And again, that's been shown repeatedly by many, many groups. So we find that there's this transient axial elongation, and certain studies show that that's greater in myopes than emmetropes. And we've also, we have shown that that effect is greatest at the fovea, at the posterior pole. We also see it across about plus or minus 30 degrees or so at the posterior pole as well, but that it's not as great in the periphery. So here we have the axial elongation at the fovea, plus or minus 30 degrees across. That's a bit further than the disc on each side, about twice the distance from the fovea to the disc, about 15, and then add another 15 on each side. And you can see that the increases in the axial length, about 40 microns in our high myopes, 30 in the low myopes, and about 25 or so in our emmetropes. They all repeatedly show this, and changes in the periphery as well, but not as great. So it's something different that's happening at the fovea that really makes it susceptible right at the posterior pole to that axial elongation. And of course, that's where we see the focus of posterior staphylomas occurring later on in very high myopes as well. We had a question about whether that was creating this axial elongation, and it's it does disappear over time if you measure over a period afterwards, after the knee work. And we find that about 60% of the axial elongation is accounted for by choroidal thinning. So that's some data that I'm just showing you here. So the eye increases in length, and the choroid increases in thickness as well. So here we have those changes in choroidal thickness in our emmetropes and myopes as a function of retinal angle. So this is actually the choroidal values, and this is the changes in thickness that we actually see. These are in microns again, so not as quite as large, 10 to 20 microns compared to the bigger changes in axial length we see. But the change in the choroid is related to the change in eye length, and it probably accounts for about 60% of that change. Also, if you just measure, it's interesting, we see that myopes have a greater choroidal thinning than our emmetropes do, and they start with a thinner choroid, and yet it thins even more. So the myopic choroid is particularly susceptible to this thinning effect, and I'm sure that's functionally not a good thing to have. The choroid is what supplies the blood flow and to the posterior retina and to many other parts of your eye, of course. So I can't end or not mention outdoor time in a talk about near work and myopia, because there's quite a lot of data that shows that if you spend enough time outside, you can actually negate these effects of near work. And I already mentioned at the beginning that in Brisbane, we do have a quite low prevalence of myopia, and we've hypothesized that that's because of our outdoor lifestyle, that we have more houses than unit blocks, lots of houses have swimming pools. People go to the beach all the time. My kids' favourite activity at the moment is going to the beach and swimming in the pool. And I have this constant kind of stress trying to stop them from actually getting sunburn all the time, because we're the melanoma capital of the world as well. So there's been meta-analysis that clearly show this, that your risk of myopia is greatly reduced with outdoor time. And a question that rises, is that simply due to decreasing the amount of near work that you do? Is that what it's about? And there are lots of different possibilities, and decreasing near work time is definitely important. But of course, going outside also increases your vitamin D levels, dopamine levels. Animal models show that when there's high dopamine, that negates and stops the eye from growing longer. There's short wavelengths, so there's all this work going on about wavelengths of light and red light inhibiting myopia. So maybe a small component that's due to the outdoor effect is due to decreasing the amount of near work that you do. Related to that, I've been involved in some work that's looking at green space in China and the relationship between that and myopia. So they can get information about socioeconomics and how much close work children do, and also where they live. And then you can get satellite imagery. It's really fascinating. And you can see based on that where all the built-up zones are, and also where the green spaces are, where there's parks, where there's trees. And they found from this work that the greater amount of greenness around where you live, so they looked at buffers 100 metres, 250 metres from the 500 metres from the children's home, the less likely you were to become short-sighted. And there's also studies that have been done looking at green spaces around schools as well, that clearly show that there's this great benefit of having green spaces to decreasing myopia risk, and also to reducing the effect of daily screen time on myopia. I didn't put it in, but I have been involved in some work looking at really young children's increased risk of myopia based on whether they were given digital devices to look at before 1 year of age. And so children who are really young infants, 1 to 2 years of age, if they spend a lot of time on digital devices, then their risk of having preschool myopia is much higher than the children who aren't given devices at that really young age. And you might go, oh, how would a 1-year-old or a 2-year-old, use a digital device? Well, I clearly remember that my kids could use iPads and digital devices before they could even talk. They're scrolling, they look at things, they're just fascinated by those devices. So this clearly does happen and is easy for children to use, even when they can't read or speak yet. So that leads me to what kind of near work advice will you give your patients? And I might actually start with this 20-20 rule that I'm sure you probably have all heard about. And so this advice is that every 20 minutes, you should look up from what you're reading, glance around for 20 seconds and fixate on 20 feet away. So this doesn't really translate in Australia because we use meters. So it would be every 20 minutes, take 20 seconds to look 6 meters away. We don't use feet here, but it's a 20-20 rule. And often I have to try and remind myself of what it even means because we don't work in feet, we work in meters. But there's no evidence that this is actually at all useful. And so there's a couple of studies that just came out early this year in Optom and Viz Science that looked at this, particularly for digital eye strain, which is another area that I'm really interested in doing some work in, and that showed that 20 seconds of looking far away was not enough to decrease digital eye strain, was clearly not going to be enough to have any effect on myopia either. And the CHIC studies even showed that you probably need to intersperse hyperopic to focus, negative lens wear with probably at least 5 minutes to negate the effect, and do this on a cycle. So just keep that in mind. You need to do more than this 20-20 minute rule. You can't sit there for 5 hours with just little 20-second intersperse and expect that to help control your myopia. But we do know, though, that we need to limit the daily amount of near work, and particularly time on those digital devices. And the literature that I've read suggests that you should need to limit to 2 hours per day or less. And I go, how is that possible? I probably spend, oh my gosh, look, I would think 10, 12 hours a day on devices, computers, doing close work, and my children who are teenagers would be the same at school every day, when they come home, on their phone, social media, doing all those different things. So that I do not think that is at all achievable to limit it to that. And maybe that's probably when they're talking about really young children, like under 3 or 4 years of age, then try to limit it to that. But older children, it's impossible. But what is important is trying to limit the intensity that's done. So the duration in one burst and the working distance. So the closer that you do hold things, the more the dioptric demand, the more the drive to become short-sighted, and that's clearly been shown. So holding things at 20 centimetres is much worse than 30 centimetres and 40 centimetres. And of course, little children with little arms are going to hold things very close, but if you can kind of help them to keep it a bit further away, then that is beneficial. So, and trying to intersperse it with going outside. Now, one of the things that's been proposed, I know in Singapore and also China, is to have all the class breaks outside, right? So, morning tea and lunch and afternoon tea and those sort of things. Well, in Australia, we've had that system forever. So they shut the classroom doors and all breaks are outside. You cannot stay in the classroom, and all that. Most of our schools are not in high rise. They're big, expansive. They have playing fields and the kids are expected to go outside. Sometimes you could go to the library and do some homework and things, but your classroom is shut. And I sometimes do wonder if that's really helped to control the amount of myopia that we see, that to really low levels. So when you walk around a school in Australia, in Brisbane and primary school, you might see 1 in 100 kids wearing glasses. It's very, very rare and infrequent. And so I do think that's something that's really useful to do. And I do wonder why that's not been implemented in all schools everywhere across the world, unless it's snowing or raining or something. So encourage going outdoors as well. And if you can't do that because of the temperature, because it's too hot in Singapore and humid, though I think we were pushing 70% or 80% humidity today and it was 32 degrees Celsius, then at least have lighting through a window so you get good natural light coming in. That's really important. And really it's just encouraging a balanced lifestyle with getting outside, not spending all your whole life in a small room, up close, doing nothing else, particularly in young children, because we know that critical period of when the eye is emmetropizing and the length and everything can change so much is when you're younger. And I always tell the students, my students as well, the story about when I was about 25, I knew I wasn't very short-sighted and I knew I was going to become presbyopic one day. I did all the wrong things where I tried just to read and do close work and read in the dark, and I did not shift my refraction at all because, of course, emmetropization peters out. And therefore, you're not going to be able to get that effect after all. And adult animal models, it can take, 2 or 3 years to push a chicken a smidge of refraction when it's older, and same with the monkey data as well. And then, of course, use the myopia control treatments that I'm sure that you're going to have lots of talks about. I saw that there was some really good CE programs coming up on myopia and control options as well. So orthokeratology is a favoured optical treatment in Australia. And, putting plus on that periphery with multifocal contact lenses and orthokeratology and those new spectacle corrections as well that puts the plus on the periphery are really taken off here, as well as the low dose atropine too. So that's the presentation that I wanted to, and what I wanted to share with you today. I hope you've enjoyed what I had to tell you. And I really thank you for listening. And I think we've got time for questions now.
Thank you, Professor Schmid. That's a very insightful talk. And we all know that near work is associated with myopia, but what you have given us is evidence-based findings. We have a deeper insight on why that is so, because of the transient change in axial length, the accommodation length, all that further explains why near work plays an important impact on myopia development or even progression moving forward. As we kick off the Q&A section, may I first invite another panelist to join us, Dr. Anna Yaw, who is Senior Lecturer at Department of Ophthalmology at the National University of Singapore. May I invite Dr. Yaw to join us as well?
Hi.
Thank you, Dr. for joining us.
Thank you.
So first off, perhaps I can reiterate this. So to the audience, if you have any hot questions, pressing questions to ask, please feel free to type in the chat box. We apologize that we can't unmute everyone and people start asking questions. That will be a little bit difficult to accommodate. Hence, we ask for your patience to type in your questions in the chat box, and we will try our best to address most of the questions. So while
I'd love to answer your question.
Oh, okay. There are some questions coming in now. Right, perhaps I paraphrase the first one because it's one of the questions that I wanted to ask as well. So some personal preference here. So Professor Schmid, going back to the finding that you reported on ciliary muscle lengthening, in myopic eyes. I presume that was and based on ASOCT imaging. Was that done mainly on the Caucasian population?
So in Australia, no, actually. So in Australia, we have this situation where, at least in Brisbane, if we want to do studies on myopes, most of our myopes are of Asian descent. So they may be third or fourth generation Australians. They may not speak any other language except English, but their genetic background is from Southeast Asia or from, those kinds of countries. And we find it quite difficult to recruit Caucasian myopes. So when we look at that data, it probably would be 2/3 from Southeast Asia.
Oh, that's interesting. And
yes,
I actually have a follow-up question. So since it's a mixture, did you notice any differences between Caucasian subjects and Asian subjects in terms of the ciliary muscle lengthening?
I don't think we had enough participants to break it up into those genetic, background groups. We do have quite a lot of peripheral refraction data where we have enough participants where we look based on race and what people say where they're from. And in our peripheral eye length and changes, we see a big difference in that our Southeast Asian group have a greater propensity for that axial length elongation with near work. And also the choroidal thinning that we see. But our ciliary muscle, we've only just been working on that recently, and we just do not have the numbers to really look at that because most of our myopes were Southeast Asian myopes.
Thank you.
So but given that, that we don't see such myopia in the Caucasian group, and we have to go to that group to actually see myopia, then I would suspect that we might not see the ciliary muscle changes because our ciliary muscle group that were emmetropes were mostly Caucasian. Does that make sense, I think? Yeah. Yeah, so I think the ciliary muscle of our Southeast Asian colleagues is different.
Oh, that will be interesting to further find out, or perhaps a future study.
Yes, we need to probably collaborate with countries like yourselves where there's so much myopia around, because particularly for children, we find it really hard to recruit enough participants to our studies in Brisbane, not in all parts of Australia, like in Sydney, that's very built up in high education demands and even greater pressure. They have much higher prevalence of myopia than we do.
Sounds good. Sounds like we have a potential research collaboration project now. Well, moving on to the next question, I'd like to open this question to both Professor Schmid and Dr. Yaw, given that both of you are myopia experts. Of course, as practitioners or optometrists and even parents, they often ask, so given the findings, the evidence that we now know, so what is the best practice now? Of course, as Professor Schmid mentioned, it has to be as holistic as possible. But at the same time, and as you know, in Asian context, in Singapore context, there's still a lot of homework. It's inevitable, a lot of near work as well. So how do we balance this? And while at the same time encourage and optimize the hours of outdoor activity as well. Thoughts from both of you?
Yeah, I mean, I'll start. So I think the literature shows that you need about 2 hours per day of outdoor time to balance all the close work. And if you get enough outdoor time, then you can do all the near work, right? So, and I think that, as I already said as well, you could spend all the lunch breaks at school outside playing sport, and that would greatly decrease your risk too. So every half hour, the half hour lunch breaks and morning tea breaks that kids get, there's at least 2 of those within the day. They're about, at least in Australia, they're 30 minutes of length. They should spend those outside. If they could do at least a sporting activity that was outdoor after school a few times a week or on the weekend, as long as you don't spend your whole day inside studying all weekend, 2 days, surely you can have an hour twice a day on the weekend to get outside, go for a walk in the park, play some sports. I mean, Anna can tell me what the lifestyle's like in Singapore. Both my children are now sorry, both. My children are 13 and 15. They're both about +1. The grandma is about a -3. Neither of them are short-sighted. They both play netball, do swimming, do volleyball, do all these activities as well, and really study hard as well and get straight A's. So it is possible to have that balanced life if you have devoted parents who take you to all these activities and sporting events and get you outside. So, but Anna, I'd be interested to hear about Singapore. What Singapore kids do.
Yeah, okay. I think recently what happened is that in the schools, the teachers kind of understand that outdoor activities are very important for the kids. And now some of the education, the classes are conducted outdoor. So the students are learning from the outdoor activities in schools. So which is an encouraging situation. So hoping to kind of reduce or maintain the prevalence or reduce the incidence of myopia in Singapore. So there was an awareness about outdoor activities.
Mm.
Yeah.
And I think it's particularly important when there's that genetic predisposition there that we know that the Asian eye has, right? So, yeah, well, for all children, it's just a better balance, happier life as well.
Thank you. So moving on to the next question. So here's an interesting one. Well, given that we know that the impact of neowork on myopia development and progression, and at the same time, we know that outdoor activities are beneficial. The optimal light level is also beneficial. So how can we combine these findings together? Say, for example, here's the question. So does that mean yes, we can't avoid neowork, but should we do neowork in an outdoor setting more, or we should do neowork in a environment where there's a optimal light level? So would that be a more feasible approach? Comments from both of you?
I think that in a perfect world, right, our eye was designed with some light and not all the artificial lighting that we have, and perhaps there is something about artificial lighting. And definitely, I think if even just psychologically and for your well-being, if anyone, like optometrists, I don't know if it's the same in Singapore, I'm sure it is, they're, often in shopping centres, in the middle of the shopping centre, in a small room with artificial light and no daylight, right? That's how we work, at least here as well, right? Controlled light environments. And that's not good mentally, it's not good for your vitamin D and all those different things. Everybody deserves natural light, at least for part of the day, to go outside to eat their lunch, and it's very valuable. And so why wouldn't that be for our children as well? So I would hope that the classrooms all have windows, that they all have access to daily light. I don't think that for certain times, or like now at night time, I've got all my artificial light on. I don't think that's a problem. There's people who think that reading is the last thing before you go to bed. That's actually not a good thing to do, because then that sort of sets up what your eye might be doing through the night period while you're asleep. The last thing you saw, if that can be not close, might be a good idea, but I don't really have any evidence about that. And then there's the new treatments that in animal models where you can rear animals in red light and they don't become myopic, and you can rear them in blue light and they don't become myopic, and it's all very confusing about the spectrum, right? And new treatments are coming out about light therapy in myopia. I'm going to see more of those. It'd be interesting to see randomized trials or data down the fact to see if they actually do anything. But as I mentioned, here in Australia, we have really low prevalence of myopia, and we have a lot of natural light in our classrooms and outside. So it can't be a bad thing. And by balancing your artificial light, as long as you're seeing natural light most of the time, I think it's probably fine.
I think in addition, I believe that in the outdoor situation, we're looking far away, and not only that, the accommodation is controlled, is relaxed. At the same time, there's this space where you don't have this, you have this zero dioptric field of view, and that really helps, I think, in terms of reducing the incidence of myopia.
Yeah, well, definitely that absolute elongation that you see when you're looking up close isn't going to happen when you look far away.
Right, here comes the next question. Well, essentially two questions, one on children and one on adult, a more general one. So the one on children, it's if for young kids using smartphone, would that, if we limit the use of smartphone, would that further reduce the incidence of myopia? Well, maybe I can quickly take this. The answer is yes, and studies have shown this. So essentially, it's what Professor Schmid has shown in her talk as well. Reduce near work, reduce screen time, and optimal light levels. So those are the important key take-home messages. And here's the other one on adults. Can high myopia in adults be reversed or become milder through interventions like outdoor time, less close work? Referring to adults, any comments on this?
Once your well, as we would all know, once your eye is elongated and big, there is just nothing you can really do to push it in and shrink it. Then I think there was some work quite a few years ago that showed that it could maybe change by a fraction, maybe 100 microns or something. But when we're talking about 2 or 3 millimeter increases, to create 6-9 diopters of myopia, that's not ever going away. Your eye is always elongated, really large, and unfortunately probably also very unstable in terms of further progression just through the mechanical changes of having such a big eye with thin outer coats as well. So it is important to make sure that people know that and your patients know that, because otherwise they might go and spend lots of money on unusual therapies to try to make their myopia disappear or go away, when that's not going to happen unless they obviously have refractive surgery. And as you have a hyperopic shift with lens changes as you get older, that can obviously counter some of it too. But your eye's always going to be longer. Anna, do you have a comment too?
I fully agree with what you say.
Yeah.
Well, here comes an interesting one on pupil reaction as well. So has there been any evidence on the association between meiosis and myopia progression? Has there been studies done in this regard?
Pupil size is often measured in all those aberration accommodation studies that I mentioned, and also they're also measured. The pupil size is being measured with the myopia control treatments, and the data suggests that if you don't have a nice, decent pupil size, so you have a smaller pupil size, that the myopia control treatments don't work as well. And that's the ones that rely on the peripheral positive lenslets, or plus in the periphery of the contact lens. You need obviously a certain pupil size to have those treatments work. Same with orthokeratology, to actually get the positive effect from the peripheral part of the lens through the pupil to create the myopic to focus on the retina for their effect. So larger pupil sizes are better for myopia control treatments to work. I don't know that's any evidence, and because we have looked at this, but I don't know that we published it, because we always have pupil size data on all the kids and all the accommodation work that we do. And there doesn't seem to be any relationship between myopia progression and pupil size, but the effect of the treatments is definitely differs.
So
actually,
question, yeah, Dr. York, go ahead, please.
Sorry, Dr. Tam, you want to ask first?
Yes, actually, was going to defer this question to you because Professor Schmid very nicely cited your previous work, particularly the one on English character, Chinese character, and the impact of this on myopia. And perhaps you can elaborate a little bit more, because I can see amongst the audience and maybe parents like myself, we are bilingual and our children have to learn both English and Chinese. So now that you have this unique study which evaluated on the impact of English and Chinese character, what is your take-home message for our audience?
Prof Tam, this was done many years ago. What I could remember is English, whether you read English or Chinese words, they will cause some contrast adaptation, and therefore, and what is the difference is that the myopes tend to have a higher contrast adaptation compared to the emmetropes. All right, so that is what I could remember after so many years. Actually, I have a question for Professor Schmid. That is with regards to emmetropization. You know, like when you show your graphs 6 to 8 years old, you have this emmetropization process going on. However, if you look at the data in Singapore, we have 6 to 8 years old children who already become myopic. So do you think our emmetropization process has been shifted earlier, or the kids just do not have the chance to emmetropize?
Yeah, obviously that data was collected back in the 1950s before there was digital technology and computers and phones and all that new work that creates myopia, right? So that eyes could naturally, in the environment, have the right kind of visual stimulation to emmetropize. So I guess I didn't make the point that that's what should happen, except for all the tech and except for all the environmental changes that we have created, right? And, you know, I'm of the generation that I didn't see a computer till I went to university. And I didn't have an iPhone until, you know, I was in my 40s or something. I didn't have a phone. You had to get on the landline and, you know, phone people, and there's, you know, you had to try to get the phone booth and all those things. So that was and that was, you know, my sort of growing up, but the 50s was obviously even before that generation. I mean, I didn't even see we had a black and white television in my house when I was 10. I didn't see color television till I was an adult. Anyway, but even that data that I showed you, the historical data, was even before that time. There was really just no tech around. So definitely visual experience limits the ability of the emmetropization system to emmetropize. And that's what I mean. I think that the system is emmetropizing to the near distances that it sees all the time, just like the animal models do when we read them in a close environment or in a really, really close environment with those cones on, they become myopic to that distance. And so that could explain why children start to become short-sighted. It doesn't explain why they don't stop at that 3 diopters. Okay, you've emmetropized to the distance that you look at. Why don't you stop now? And instead they just keep getting worse and worse and worse and worse, right? But I think if you gave them the opportunity, the eyes would emmetropize. I think it's that we don't. And there was that data that I showed you from Hong Kong, which it did kind of show that the kids at around 3 were emmetropic mostly, and then they became short-sighted afterwards once they started school at 3 to 4 years of age and started really doing the intense close work, which again points to that environmental influence on what's happening.
Thank you. Thanks for the answers.
Thank you, Professor Smith. So I think that is a very insightful perspective and a very important one. So essentially that means with all the findings, evidence that we know now about intervention, the intervention probably has to take place earlier. Intervention, especially the easier ones, the more actionable ones, on environmental modifications. So probably those are the ones that we should implement even earlier, so we can delay the onset of myopia and reduce myopia progression.
Yeah, I hope that the audience have enjoyed my presentation. I hope that it's piqued your interest and that you're going to do more myopia studies and do more myopia CPD and maybe change how you practice as well. And you know, the least that you can do is give some really good visual habit new work advice. It doesn't cost anything to patients to do that as well.
Thank you, Professor Smith. It's 7:30 now, well, almost 1 minute. I would just like to wrap up by once again, thank you, Professor Smith, for the wonderful, insightful talk. which is beneficial for both our optometrist colleagues here and ophthalmologist colleagues alike as well, who are very much interested in the topic of myopia. And it's a huge topic, and we are happy to start off this topic on the role of near work. And we look forward to many more talks from you, Professor Schmid, and research work from your team as well. So we very much look forward to it. Thank you once again.
Thank you very much. Thank you.
Thank you. Have a good night, everybody. Yep.
Thank you. And for the audience who are still online, once again, please stay tuned for our webinar series. This is the QR code, as you can see. Feel free to scan it, check out our link. We have many more webinars coming up, ranging from innovation, community eye care, optometry related, and precision medicine. And on the notes of optometry education, as the optometry education program director, I'm happy to announce that next Tuesday, we'll be launching our first optometry related short course on cataract detection, post-surgery care management. So it's a 4-day course, very exciting, lots of actions, and there's also a lecture option available as well. And in May, we have another one, which Professor Smith kindly advertised for me just now, on pediatric refraction and myopia management. Again, it is a 4-day, four half-day course, 2 lecture sessions and 2 hands-on workshops. And this one is particularly on pediatric refraction and myopia management. So very closely related to what we have just talked about, and I'm sure it will be highly relevant to our optometry friends and colleagues. And last but not least, I would like to once again highlight the launch of our new Center for Innovation and Precision Eye Health, which is happening on the 25th of March. It's a Saturday, and we welcome anyone in Singapore, or if you wish to fly into Singapore to attend this. And please feel free to check out the link, scan the QR code, ISVP, and we shall reserve a slot for you. And lastly, next Tuesday, we have another webinar, and this is a very exciting one. We have with us Professor Piers Keane from Morpheus, UK, and Professor Piers Keane, he is one of the key opinion leader in artificial intelligence, deep learning application in ophthalmology. So his talk will be on innovation, deep learning application in ophthalmology and eye care. So it will be a very interesting and exciting one. So with that, I would like to conclude today's session. And once again, thank you all for being here with us. Thank you, Professor Smith, Dr. Yor, for the insightful perspectives and loads of evidence-based findings that is going to help us in our clinical practice. So thank you once again very much. And for those online, we shall see you next Tuesday. And take care. Thank you. Bye-bye.
Good night, everyone.